Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. It's our great pleasure to welcome one of the foremost educators and speakers in our profession, Dr. Steve Farrucci. He's currently Chief of Optometry at the Sepulveda VA Ambulatory Care Center and Nursing Home. He is also a residency director at that site and a professor at the Southern California College of Optometry, the Marshall B. Ketchum University College of Optometry. Dr. Ferrucci has lectured and published extensively with a special interest in diabetes, diabetic eye disease, AMD, OCT, and fluorescent angiography. He's a fellow in both the American Academy of Optometry and the Optometric Retina Society, and he's a past president of the Optometric Retina Society. So we're going to be in it for a great treat, a person who is very, very knowledgeable, very experienced in retina. And not only that, stay for an extra few minutes at the very end. Dr. Ferrucci is going to push back from his computer, turn around, face the piano, and do a song for us. So with that, please welcome Dr. Steve Farrucci.
Thanks for that lovely introduction, Joe. The only song I could play on the piano is Chopsticks, so I don't think anyone will really want to hear that, but thank you. And
at least that's a song. At least that's a song you could sing well, right?
I can't sing, so we're in for some trouble. Thank you so much, Joe and Greg, for inviting me. And I've known Joe for too many years. I've known Greg for not quite as long, but it seems like longer some days, quite frankly. But anyway, I do want to thank you guys for inviting me. So this course I put together is called Refer or Relax. And I put it together a couple of years ago. And here's the disclosures. They always want us for code purposes to mention the companies that we deal with, and there's a couple companies that I deal with, none of which I think I'm really going to address tonight. And if I do, I will do so in a fair and balanced manner. So I put this course together, and the kind of the gist of the course is I'm going to present various retinal cases. And these are cases I really think as a primary care optometrist, you'd see in your practice. And the question is this a case that should be referred to a retinal specialist, or is this something you can monitor yourself, in your practice? So it's either refer or relax. So that's kind of the gist of it. And, as we go through, I think you'll understand. And I will try my bestest to, look at the chat monitors when I can. So if you guys have any questions, you can put them in there and I will try my darndest to answer those questions. I always say there's no right or wrong answers, just differences of opinion. And, as optometrists, some of us are a little bit better at one thing than another, right? And I work at a VA. I've been at the VA for 20 years. I spent about 3 years before that at Indian Health. I deal with a lot of diabetes in the past and the present. And now I have a large AMD practice as well, and a lot of retina. So I'm very, very comfortable with retina. I have a great relationship with our retinal specialist. So I'm very comfortable with retina. On the flip side, anterior segment, isn't my forte, and contact lenses is not my forte at all. I think the last contact lens I fit was a SureView contact lens. It was a fine contact lens. I understand they don't make them anymore. I don't really understand what the problem was, but they don't make them anymore apparently. So we all have our strengths and weaknesses. So as I go through cases, I'm going to kind of give you my opinion on when you should see the patient back, or if it's something you need to refer, or when you might want to consider a referral. But again, a lot of it's based on your own practice style and how comfortable you are with certain things. That's why I say there's no right or wrong answers, just differences of opinion. So I'll give you my opinion, but if you're not comfortable in a situation, it's always best to get that second opinion. And I always tell people, and I know people who have gotten in trouble for not getting a second opinion, but I don't know anyone who's ever gotten in trouble for getting that second opinion. So, if you're not comfortable, get that second opinion. But I'll give you my thoughts. No right or wrong answers, just differences of opinion. Just kidding. There really are wrong answers. So that's what we're going to do tonight. So here's an example. 28-year-old male presents with eye pain in his left eye for 1 day. And that's his presentation on clinical exam. So the question is this something that you're going to refer, or is this something that you can relax, right? So, and this is probably referral, though you could probably fit a contact lens on that dangling eye there, but no problem, and probably bill for it as well. So
Maybe Visine extra strength there, boss.
that might help. Get the red out.
Let's get some red out. Yeah.
Yeah. So that's what we're going to do as we go through. Okay. So, so here's a 20. So first case, here's a 27-year-old male, just comes in for a routine exam. He says his distance vision, he noted, is a little bit decreased. When we asked him when his last eye exam was, he asked if having your eyes checked at the DMV to get a driver's license counted for an exam. And we had to explain to him that doesn't really count as a comprehensive eye exam. His vision's pretty good. It's 20/25 minus. Ocular history, he's never had his eyes checked practically, so he has no history. Medical history, probably doesn't go to the doctor as well. So here's his prescription. You can see he's just slightly myopic with a touch of astigmatism. Anterior seg, IOP normal, but this is retina referral relaxed, so we don't really care what his anterior seg looks like anyway, because we're going to get into his posterior seg. So here's his posterior seg. This is his right eye. It's sort of superior temporal in his right eye, and you can see he's got this sort of elongated lesion with a little bit of pigment here, and then he's kind of got these whitish looking blood vessels crossing across that lesion. So so what do you all think that is? If anyone wants to put in the chat, what they think that is, and make sure that everyone's paying attention a little bit. So if anyone wants to put in the chat what they think that is, I'll just wait a second. Well, sure. So someone appropriately said lattice degeneration. So that's great. So a nice representation, I think, of lattice degeneration. So we have a patient here with lattice degeneration. And whenever I see a patient with lattice, one of the things I always want to ask about are flashes and floaters, right? Do you have any flashes or floaters? Now, some of us may have an intake form in our clinic where they check off certain things. Do you wear glasses? Do you have headaches? Do you have blurry vision? Do you have flashes, floaters, whatever the case is? And that's helpful, sure. Or maybe you have a tech who asks entrance questions when the patient comes in, and that's also great. But whenever I see something like this, flashes, floaters, or later we might talk about some holes. If I see a patient with a retinal hole or something, I'm going to ask them again, do you have any flashes of light, or floaters? I'm going to ask them again because, sometimes people aren't paying attention to that intake form, or maybe they don't understand the question and they just check everything off no because they don't understand the questions. But you really want to know when you see something in the retina, especially in the peripheral retina, does that patient have flashes and floaters? So I'm always going to ask that patient again. So I asked this patient this. So he's a low myope, right? He's just got a little bit of a low myope astigmatism, lattice degeneration, asymptomatic. So we asked this patient, do you have flashes or floaters? He says, what's a flash and a float, right? Doesn't know. Explain it to him. No, I don't have those. So is this a referral or lack? So asymptomatic lattice degeneration, relatively low myope, or very low myope, to be honest with you, right? So refer or relax. What do you guys think? I'll wait until a person or two. The first one said relax. Let's see. And I would agree, right? I think this is relax, right? Relax and patient educate. Nicely put. Patient education is important in these cases for sure. But I think you do have to ask a couple more questions just to make sure it's fine, right? Again, flashes, floaters. You want to know about those flashes, floaters. Any family history of retinal detachment, right? If they say, oh yeah, my dad had a retinal detachment, maybe that increases my level of suspicion and might increase my level of worrisome, and maybe I want to get a second opinion. Now, if you ask patients any family history of retinal detachment, they might not even know what a retinal detachment is, might not be able to answer that question, but I always ask it anyway. It makes me feel better. I've always wondered, I work with residents every year. Every year I have 3 residents come into my VA, and at the beginning of the year, they'll come and they'll present a case to me, and they're always a little bit nervous. I guess I make people nervous. I don't get it, but they'll come to me and they go, oh, it's a 65-year-old male with a family history of cataracts. They go, oh, they have a family history of cataracts? Oh yeah, their grandmother had cataracts. Why do I care if someone's grandmother had cataracts, right? Everyone's grandmother had cataracts. No bearing on my life, but they love to ask that question. So whatever, it drives me nuts. Vocation or avocation, right? So maybe if you see a patient that has lattice and they have a vocation or an avocation where they get hit in the head, have head trauma or something like that, maybe I would think about getting a second opinion. Years ago when I was in private practice, I saw a young kid who had a lot of lattice, And just talking to the kid, it turns out he's a high school running back, and apparently a pretty decent one from what he told me, right? So he's a running back. He's got quite a bit of lattice, and he's constantly getting hit during football practice and during a football game. Well, maybe I want to get a second opinion on that, right? I have a patient now who's a retired police officer. And for fun on the weekends, he does amateur MMA fighting, right? So on the weekends, he does this MMA fighting, and he's getting hit in the head, he's getting kicked in the head, and all this sort of thing. So again, maybe a patient like that, maybe you want to get a second opinion because it probably increases their chance of having a retinal detachment, right? It's not 100% clear from the literature, but it certainly can't be good. This guy,
Steve, I think the actual medical term for a lot of lattice is lattice.
Lattice?
Yeah, lattice that's the technical medical term for a lot of lattice.
I might have to use that and take credit for it, by the way. I just want
Go right ahead. Just when you think of me, think well.
There you go. That's all we can do. That's a good one, though. I like that. This guy, though, the guy literally, I have this patient, he's a retired police officer. He's huge. Like his arms are like, as big as my waist. He's huge. And he's like, oh, you should come down to the gym sometime and train with me. And we could do something. We could get in the ring together. I'm like, yeah, no, I think I'm busy. He goes, I didn't tell you when. I'm like, I'm still busy, right? Not interested. Let's see. Whoops. Yeah. So if they have, certain things that increase their risk, maybe I want to get a second opinion. So this patient, we talked to them. They really don't have any risk factors at all. So we explained to them the signs and symptoms of retinal detachment and to come back and see us. On this particular patient, I said to come back and see me in a year. Perhaps it's the first time you've seen the patient, they have lattice. Maybe you want to have them come back, a little bit sooner because it's a lot of lattice, or you don't like it, or you just want us to have the patient come back sooner. That's perfectly fine. But these are 99 times out of 100. This is nothing to worry about. But again, what if the guy says he does MMA for fun, right? What if they're a high myope? We do know from some studies that high myopes are at increased risk for retinal detachments if they have lattice, right? What if the patient has an RD in his other eye for whatever reason, right? What if the patient's monocular and this is his only good eye? Again, these are mitigating circumstances that maybe you want to get that second opinion. Help you sleep better at night. What if the patient's a lawyer, right? It's unfortunately, we live in a litigious society, and it's a litigious society. And what if the patient's a lawyer? Maybe you want to get a second opinion on that, right? What if it's your father-in-law and if anything ever went bad, you'd never hear the end of it, right? What if it's your favorite neighbor and you see the guy all the time taking out the trash and you always chat with the guy? What if it's your least favorite neighbor, right? So there's always mitigating circumstances. What if the patient's going to have cataract surgery? The cataract surgeon I work with now, if he sees a patient with a lot of lattice or another retinal condition, sometimes he'll send her over to Retina just to get a second opinion and get the okay before he does cataract surgery. And why does he do that? Well, I said earlier, it's a litigious society. So he wants to make sure that he gets an okay from the retinal specialist saying, yeah, you can go ahead and do surgery just in case something goes bad. I mean, one of the potential complications from cataract surgery is a retinal detachment. If he has a patient that has a retinal detachment, he wants to be able to say, hey, I sent him to a retinal specialist. I got the okay to do the surgery. It's kind of a bad outcome, but not my fault, right? Or what if it just looks bad? Those of us who have been practicing for, long, I've been practicing for 25 years or so, every now and then you just see something, you're like, man, I just do not like the looks of that. And if that's the case, get a second opinion. Again, no one's going to fault you for getting a second opinion if you're not comfortable with something. You can only get in trouble if you don't get that second opinion. So lattice is relatively common. And if you look at the studies, they claim it's about 5 to 10% in the general population. So relatively common. That number to me seems slightly high because we dilate, virtually all our patients, and I don't think I see it, quite that much. But it's common, right? And, you're going to see it. If you dilate all your patients, you're going to see it, rather routinely. It's found in about 30% of all retinal detachment cases. So because of that, for a long time, people felt that it was very highly associated with retinal detachments. But this ophthalmologist back in, I believe it was the late 80s, did a relatively large study, and he followed patients that had lattice for about 10 years. And what percentage of those patients that he followed with Lattice for 10 years, what percent do you think went on to get a retinal detachment, right? So if anyone wants to chat, I like to keep it interactive, and then it's less work for me too. But
No, and Steve, that's greatly appreciated because, it's the whole idea of these. If they want these to continue to go, they need to be live and interactive. And that's why we have the polling questions. But thank you for doing it this way too.
Sure. Well, we'll do the polling questions too. Yeah,
Yep.
so I'm getting some great answers there. 5%, 1%. So those are all great answers. And really the answer is less than 1% of all Lattice. So there was a big study, low. I like that. What percentage? Low. I like that. There was a study concluded in 1989. This retinal specialist Bayer followed patients with Lattice for 10 years, and he found 0.7% went on to have a retinal detachment, right? So can it happen? Yes, but it's relatively low. So that's why I say if you have a patient with Lattice, you don't want to send every patient with Lattice off to the retinal specialist because you're going to be over referring patients to the retinal specialist. But if they have any of those risk factors, right, a super high myope, retinal detachment in the other eye, high risk behaviors, stuff like that, then you get the second opinion because those are the patients that are more likely to have issues. But I always tell my patients with Lattice, 99.3% chance this is never going to cause a problem. So you want to look for those that are at a higher risk, right? So just some other photos, these could be, hard to photograph sometimes. Sometimes you can get little holes in them as well. It might be hard to see here, but sometimes you get little holes within the lattice. And what they've actually found from studies is that if you have a hole within the lattice, those are a little less worrisome because above the lattice is no traction. The vitreous overlying a lattice lesion has become liquefied. But if you have holes on the end of the lattice, right, there's usually traction at the end of the lattice. So those are a little more worrisome. And when we go through this lecture, you'll see that a lot of times I'll mention the fact if there's if there's traction involved, if the patient has active traction, that's usually worrisome. Lack of traction is usually a good thing. So with these holes, if it's in the middle of the lattice, lack of traction, usually a good thing. If it's at the end of the lattice, a little more worrisome, not horribly, but a little more. Some other pictures, this is a big hole, right? That's a big hole within the lattice. Maybe I see that and I don't like that. So then I move on from that. Maybe I get a second opinion on that one. I don't like it, right? I just kind of like this picture. It's from an old book that we used to have back in the day. I was trying to explain to my residents before we had cameras, people actually drew stuff. They're like, what? I'm like, that's what happened, right? But again, you can see a hole within the lattice, little less worrisome than a hole on the end of the lattice, okay? So circumferential oval lesions, often with thin white blood vessels, that's why they called it lattice in the first place. Pigment can vary. So if you have a patient who's darkly pigmented, Hispanic American, African American, what have you, they might be a little more darkly pigmented than a white fellow like myself might be less pigmented. And like I mentioned, the vitreous adhesions on the borders, that's why holes at the borders are a little more worrisome. Holes within it are not, because you have synoretic or liquefied vitreous overlying the lesion itself. You can have round holes within the operculum about 30% of the time. Most common in the superior and inferior retina between 11/1 and 5/7. Typical lesion size 1/2 to 2.5 disc diameters in width and 1 to 4 disc diameters in length. Average number of lesions per eye is 2. The range reported in the literature is between 1 lesion and 19 lesions per eye. Now, again, if I saw 19 lesions in one eye, right, that's an eye, maybe I'm gonna want a second opinion on that, right? I've never seen that many in one eye. I've seen, 3 or 4, maybe 5. I don't think I've seen more than 5. I can't recall anyway. But if I saw 19, right, I would maybe rethink my thought process, right? And bilateral in way more than 50% of cases. And it's fairly bilateral. So if I find it in one eye, I always want to check the other eye in the same clock hour. So if I see it at, superior in one eye, I always want to look superiorly. I'm going to look everywhere, obviously, but pay particular attention superior in the contralateral eye. And more than 50% of the time, way more than 50%, it is bilateral. Most new, whoops, sorry about that. Most new cases are discovered between 10 and 20 years of age. And they think that it's probably, you know, already there from earlier in birth, almost from birth, but 10 to 20 years of age is often the time when someone gets their first dilated eye exam. So that might be the first time it's discovered, even though it may have been there previously. May have a hereditary component, no apparent gender or racial bias. So it can happen males, females, and any type of race. It really doesn't seem to have any bearing on it. And just some other pictures, you know, Optos. Optos is a great way to document lattice. In my opinion, it does not take the place of a dilated retinal exam, especially in a symptomatic patient, right? If you have a patient complaining about flashes and floaters, you really have to dilate that patient. So I'm not a huge fan of doing this in lieu of a dilated retinal exam, but I think in conjunction, it's a nice way to monitor for things and make sure that you're not missing anything. Another example here of some lattice, and the patient also has another lesion, which we'll talk about a little bit later, actually. So some risk factors to think about when you might want to get a referral, right? Myopia greater than 3 diopters if it's a young patient, less than 30. Myopia greater than 6 diopters at any age. The fellow eye has a retinal detachment. Family history of retinal detachment. Symptoms, if you ask the patient, do they have symptoms? And they say yes. Presence of traction, you know, that's very hard to ascertain, quite frankly. The best way to tell would be able to do an OCT over the lesion, but these are peripheral lesions. And unless you're, you know, have a very good tech who can really get out into the periphery, that you probably will not be able to tell. And then high risk behavior, a running back, someone who's doing MMA for fun or something like that, you might want to get a second opinion. So I think if you have a patient with lattice only and don't have any signs and symptoms, think about scleral depression. I'll talk a little bit more about scleral depression a little bit later, but this isn't a bad time to break out that old scleral depressor that they made you buy in school for $120 or something and you don't use it much. Try it, right? And for God's sakes, don't use a Q-tip. I've heard people say, oh, you can just use a Q-tip. Don't use a Q-tip. If nothing, it just looks so like, oh, it drives me crazy. Don't do that. But you know, if they just have lattice and nothing else going on, you could see this patient back in a year. Again, maybe it's the first time you've ever seen the lattice. You want to have them come back in 6 months. It's stable in 6 months. Then I'll see him back in a year. If they have symptoms of flashes and floaters, you know, I would see the patient sooner, you know, maybe 6 months, maybe even a little bit sooner, maybe 3 months. Again, if you're not comfortable and they have signs and symptoms, right, they have flashes and floaters, if you're not comfortable, you can consider referring them out to your friendly retinal specialist to get a second opinion. And then I would have them come back and repeat DFV with the scleral depression as well. And patient education, like someone, you know, astutely pointed to in the chat box, patient education is really important to these patients. You need to tell them, hey, if you notice any signs and symptoms associated with retinal detachment, flashes, floaters, more floaters, right? Decreased vision, curtain over your vision, whatever, you call me right away or come in right away. Lattice with holes, but no risk factors. You can try scleral depression on those. I think it's a good idea to try it. Have the patient come back sooner. If they're a young myope, a myope more than 5 or 6 diopters, if they have inferior holes or adhesion, you might want to see them back even sooner. And if they have risk factors for retinal detachment, you know, they had a retinal detachment in the other eye, they're high myopes, whatever, you know, think about getting that second opinion on them. And, you know, I have a good friend of mine who's a retinal specialist up here in San Fernando Valley, where I live just north of Los Angeles. And he's a friend of mine. He's a retinal specialist. He met him years ago when he was going through, he was an ophthalmology resident through UCLA. He rotated through my hospital, and we've been friends ever since. And we were talking one day, because remember a couple of years ago on ODs on Facebook, some optometrist tried to send a patient to a retinal specialist, and the retinal specialist or someone in the retinal specialist's office faxed back this optometrist and said that I don't take patients from optometrists, right? And I showed it to my friend who's a retinal specialist, going, that's the stupidest thing I've ever seen, Steve. He goes, I get a lot of referrals from optometrists, and the the optometrists often send me some of the best consults, you know, that there are, because they know what's reasonable and what's not. And he told me once, he said, I'm happy to see any optometrist, you know, as a second opinion. And he said, one of the reasons that I do it, Steve, is he said, if you saw my malpractice bill, you'd be shocked. He said, it's absolutely atrocious how much I pay for malpractice. But part of it is to cover myself and to cover you guys. So if you send me a patient, right, for a retinal issue, essentially I'm taking over responsibility for that patient. So if it's something that really looks weird, you're going to lose sleep over, geez, I'm really worried that this is going to go south, get a second opinion. Send them to your friendly retinal specialist, and you'll get a second opinion. I've worked with a lot of ophthalmologists through the years at the VA and at Indian Health, where I was for a couple of months. And I think retinal specialists are sort of the easiest to deal with, because they have no desire in stealing our patients, right? And as a matter of fact, my friend I was just telling you about, he opened a new office. I went to look at his office, beautiful office. And he said, do you notice what's missing? And I go, not really, what? And he said, 4-opters. Because I do not have one 4-opter in my office, because I don't want to even be tempted to have a patient say, oh yeah, I need new glasses. He goes, I just tell them, I don't do that. Go see, you know, your local optometrist or whoever sent you over here. So yeah, so just keep that in mind. You can always get that second opinion. Someone said they had a retinal specialist do scleropression and it hurt for 2 to 3 days. I had a friend of mine who had a lot of lattice. He went to a doctor and he said it was a little uncomfortable too. I always say though, you know, it should be a little, if you're doing it right, it shouldn't hurt, but it should be slightly uncomfortable for the patient. If the patient doesn't even know you're doing it, you're probably not doing it correctly. And we'll talk about sclerodepression a little bit later. And then if you have lattice or breaks at the margin of lesion, you know, those are the ones that have been shown to maybe be predisposed for retinal detachment. Consider retinal consult. This is snail tracking. And I remember when I was in school, we had a teacher whose name escapes me, teach us, you know, retina and ocular disease. And they made a big deal about, you know, lattice versus snail tracking. And I remember on a test, I said it was lattice. And he said, no, it's snail tracking. Like it matters. Doesn't matter at all. Same risk factors, same exact thing. So it just looks different, but same thing. So that's my spiel on lattice. Again, 99.3% of the time it's safe. I think our job is to use those risk factors I talked about and figure out those 0.7% that are high risk and get a second opinion on those 0.7%. The treatment, by the way, you know, if they saw a retinal specialist and the retinal specialist didn't like what they saw, they could in theory do prophylactic laser around you know, an area of lattice to prevent it from ever detaching. And that's essentially what they do on these. And you know, I talked to my retinal specialist. We've known each other. We've worked together for 20 plus years. And I asked him once, we were just talking about something. I said, how many times in your career? And he's probably mid to late 50s, I'm going to guess. I said, how many times in your career have you treated lattice? And he said, oh, maybe, he goes, maybe more than, you know, maybe more than 5, but less than 10. So he said, I really don't like to treat unless there's mitigating circumstances. And he told me he actually treated a running, he wouldn't tell me who, but a running back for UCLA, actually, he treated because of his, you know, predicament with getting hit and stuff. So again, it's very, very safe majority of the time. So here's our second case, 60-year-old male, flashes temporally in the right eye for a week, also having some floaters. And the vision was unaffected. His vision was 20/30, which was normal for him. He's got a little bit of macular degeneration and a little bit of a cataract and a little bit of a corneal foreign body. So his vision's normally around 20/30. And this patient was set up from the primary care department, the urgent care actually department. And I've worked pretty much most of my career, I've worked in a hospital-based setting. So I've worked with physicians. I've worked with, you know, other disciplines as well. And one thing I can tell you, and it's no disrespect to primary care physicians, but they don't know much about the eyes. They really, really don't. And their training in the eyes is never been good. And now it's getting even less. And I was just talking relatively recently to a medical resident from UCLA. And back in the day, we used to have the medical residents from UCLA would come up to the eye clinic and spend a couple, like 2 weeks or so in the eye clinic just to kind of learn something, to get some exposure to eye care. We haven't been doing it, you know, in a couple of years because they just have so many other things they have to do. They just couldn't fit in this 2 weeks, which is, you know, fine with me. But we try to teach them stuff. But you realize that the primary care doctors, you know, don't really know a heck of a lot. We had a kid up here. The last kid that came up here, this is when I decided maybe this isn't worth my time. We had a fella come up, and he was a medical resident, and we're trying to show him around and teach him a couple of things. And we saw just a regular run-of-the-mill conjunctivitis, just a run-of-the-mill bacterial conjunctivitis, classic, you know, the eyelids shut in the morning, and he had the goop on his eyelids and, you know, everything. So I said to him, I said, hey, you know, we have a patient here that has just a very normal conjunctivitis. This is something you might see in your primary care practice or an ER. You know, why don't you take a look at it so that you know what it looks like? And for God's sake, don't treat it with sulfacetamide, right? Because primary care physicians, I don't know if they have stock in sulfacetamide, but they love sulfacetamide. So he says to me, he goes, nah, he goes, I prefer not to. I'm like, well, why not, right? It's just an eye infection. It might be helpful. He goes, no, he goes, I think I'm good. And I said, okay, well, whatever, but like, I don't get it. And he goes, just between you and I, he goes, I find eyes disgusting. And I said, oh, you know, okay, eyes are disgusting. I said, what field are you thinking about going into? He goes, probably proctology. And I'm like, okay, eyes are gross and you're going into proctology. Good luck, my friend, right? So anyway, but the one thing that the primary care docs know is that if someone says they have flashes, oh my God, they're having a retinal detachment, right? So they don't know a lot about the eyes, but they know flashes equals retinal detachment. So working in a hospital, it's at least once a week, if not more, sometimes more. You know, it seems really lately, it seems almost daily, but I get flashes sent up to me from urgent care, and you know, usually they're nothing. Sometimes there's something, right? But very, very common. And that's primary care docs. Like I said, if they know nothing else, flashes, ooh, that means they're having a retinal attachment. It's got to be checked out, right? So anyway, so this is that patient. So he comes up to see us. And again, you know, sometimes these peripheral stuff is not the easiest thing to photograph, but you can see here he's got a lesion, right? And it kind of has this U-shaped lesion here with a little flap here and a cuff of edema around it. So what do you guys think that is? So what do you think that is?
It looks like a Sasquatch to me.
A Sasquatch. You're very helpful, Joe. Thank you. Okay, so we got an RD. I would say it's not an RD, but it could lead to an RD. Yeah, horseshoe tear. So that's what I'm trying to show you there is a horseshoe tear. So we have a horseshoe tear here in a symptomatic patient. So he has flashes, floaters. We dilate the fellow. He has a horseshoe tear. So is this refer or relax? And someone's beaten me to it, right? But this is a refer. And I always tell people, there's not a lot of ocular urgencies or emergencies in optometry, but this is pretty high up there, right? And if you have a patient with symptomatic PVD, which is what this patient has, you know, that's going to be a referral. And when I say referral, this is usually like a same day referral, in my opinion, right? This is get on the phone. Hopefully you have a nice retinal specialist that you have a nice communication back and forth with. This is a get on the phone, call his office, ask to talk to him and say, hey, listen, I have a patient who has a symptomatic PVD, infranasal or supratemporal, wherever it is, right? He's been symptomatic and, you know, I really want you to take a look at him. When can you see that patient? Now, most retinal specialists, if it's symptomatic, they're going to tell you, oh, you know, send him over today or first thing in the morning. If they say, you know, send him over 3 weeks from Tuesday, call somebody else, right? Because these really are an urgency. And I want to get these things seen sooner than later, because the longer they have a tear like this, it's symptomatic. Symptomatic means you have traction. If you have traction, it can pull on that flap and make it worse and lead to a retinal detachment. So if it's symptomatic, I'm making a same day call over to my retinal specialist. Now, a lot of times you'll find these asymptomatic. You just dilate the patient and you look and you find this and you're like, oh, you know, look at that. You ask the patient, flashes floated, no, 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 no. Now, I'm still going to call my retinal specialist for that. And I'm going to tell him, hey, listen, I have a fella. He's an asymptomatic horseshoe tear, but I found it on routine exam. Tell him the location. When do you want to see that? When can you see this patient for me? And, you know, most of them will, it's asymptomatic, not quite the urgency as a symptomatic one, but most of them will say, you know, send him over today, tomorrow, and let me take a peek at it, right? Because these things can lead to a retinal detachment. So patient has a laser the same day, and this is how they write it sometimes in the chart. So this is number 140. What that is, that's a laser spots that they put to surround this lesion and seal it off so it doesn't continue to get worse. 420 milliwatts, that's the power that they put the laser on. 0.15 seconds is the duration of the laser burn. And in this particular case, they use an indirect ophthalmoscopy laser. So you can do this a couple of ways. You can do it at like a regular YAG type laser, where you have a lens you can put on the patient's eye and do it through either a mirrored lens or a condensing lens. Or you can, now they have lasers, it's like a binocular indirect that you're going to do, you know, regular retinal exam, but it's also hooked up to a laser. So you can just do the laser through the 20 diopter lens on this binocular indirect. And that's what they did. It just so happened that my retinal specialist, he comes up every Friday. This patient was sent up to me on Friday, and I saw him and I talked to the retinal specialist. He said, I'll just laser him now. So, but again, to me, these are same day referrals, or at least a call to your retinal specialist to get their opinion. Guy came back a week later. He's doing well. He still had a couple of floaters, but no flashes. Vision's fine. And you want to look at these patients. You want to make sure that the laser looks good, that they have a nice pattern encircling the lesion or the tear 360 degrees. And he looked good, so we give him RD precautions and make him a routine patient, and we see him currently. The retinal breaks, like horseshoe tears, occur in 3 to 7% of the adult population. Again, personally, I think that number is a little bit high. One of the problems is a lot of these numbers that look at how common things are come out of retinal specialist office. And if you're a retinal specialist, obviously your percentage of retinal findings is going to be higher than a general optometrist or general ophthalmologist. So that's why I say the numbers are helpful to give an eye of relative commonality, but the numbers aren't that important. They can often be asymptomatic, and 1 to 2% with breaks, progressive retinal detachment. I've actually read a more recent study that puts that number up quite a bit higher, around 20%. So about 20% can progress to detachment without treatment. And certain risk factors, if there's concurrent lattice, high myopia, atrophic holes, aphakia, pseudophakia, and a history of trauma, even more likely to have detachments. Common locations of horseshoe tears: near lattice, near pigment clumps, and near chorioretinal scar. And the reason being, especially with the pigment clumps and the scars, is that when you, the vitreous will tend to glom on or attach a little bit more firmly to a pigment clump or a chorioretinal scar. So then when the patient has a PVD and the vitreous kind of gets pulled forward, it's going to pull a little bit more on that pigment clump. And that might lead to a horseshoe tear right adjacent to that clump or scar. So we see this sometimes. A worse location, superior, because of gravity, more likely for fluid to get behind it and cause a detachment. Near the equator or closer to the posterior pole. So the more peripherally they are, the better, the more safe they are. The closer to the posterior pole, the more worrisome they are. And just another example of a horseshoe tear. Here's a horseshoe tear that did in fact lead to a detachment, and you can see that it's detached around that tear. Here's a nice picture that was given me by the folks at Optos, of a nice horseshoe tear here. And again, a nice way to document these things, but does not take the place of a careful retinal exam. So if they do treat these, or when they treat them, these are generally treated. 99 times out of 100, people are going to treat a horseshoe tear unless there's a reason not to treat it. But they're probably going to get treated almost always, especially if they're symptomatic. So laser treatments used to seal the break by creating adhesion between the retinal tissue and the underlying RPE. So essentially what they do, and I'll show you a slide in a second, but they have the little lesion, right? They're just going to do a bunch of laser and encircle it all the way around that lesion. That will prevent that lesion from getting bigger or fluid from getting behind the tear and causing it to expand. So I always tell patients, it's sort of like, you have a little hole or a tear, and it's sort of like if you had a hole or a tear in your favorite t-shirt, right? If you just sewed around it, the hole's still there, but it's going to make sure that hole doesn't get any bigger and then ruin your favorite shirt. So it's the same thing when we have a hole in the retina, right? Once they do the laser, it is solid within 24 hours. So after 24 hours, they're actually pretty safe. Now, one thing I've heard is that, if you see pigment in a patient's eye, so if you see a retinal hole, tear, or break, and you see some pigment surrounding it, and it's not pigment from a laser, but it's pigment that the body itself has deposited around a lesion, people say, oh, there's already pigment there, it's safe. That's not necessarily 100% true. What they found from studies is that when you do laser like this, it really creates a seal between the retina and the RPE, almost a watertight seal, if you will. The pigment that your body forms, in relationship to a hole or something, it's not strong enough to create a seal all the way from the retina all the way through the RPE. So if you see a hole or a tear or a break with pigment around it, it's safer than one without it, because it means at least it's been there for a certain period of time, usually 3 to 6 months by the time pigment can accumulate, but it can still detach. And I don't know if any of you have seen this, but I've had patients who have had like a chronic retinal attachment. So you see the retinal attachment, and then there's a line of pigment. And then you see a second detachment and another line of pigment, and a third line with another line of pigment, because that pigment's not strong enough to firmly seal the retina. Laser is. So just keep that in mind. The pigment's safe, but it's safer, but it's not 100% safe. So I just wanted to make that clarification. So this is how they treat it. Again, you've got the little lesion, and they put a couple layers of laser around that lesion so it does not get any bigger. Generally, they do topical anesthesia. If you talk to patients after they do this laser, they'll say, oh yeah, it felt funny, it stung a little bit, but it's not supposed to hurt. They can do retrobulbar anesthesia, where they stick a needle under the eye and numb up the eye if the patient really is in a lot of discomfort or is moving their eye around and really won't sit still. But no one really likes to do retrobulbar anesthesia unless they have to. So generally topical is enough. You want to see the patient back for 2 to 4 weeks or so after the surgery to see how they're doing. If it's larger or superior, you want to follow those patients even closer. What you want to do is you want to look at the area that was treated. You want to make sure that it has a nice pattern of laser 360 degrees around that lesion, and there doesn't appear to be any subretinal fluid or edema that's escaping beyond the barrier. And then, you might want to see them back a couple months after that. And then once they're stable, you can just put this patient back on their normal recall. And I always do tell them, if you ever notice flashes and floaters in your other eye, please make sure you come back and see us as well. The laser surgery is actually relatively benign with very few complications. You can see those complications here, but really these complications are few and far between. And most patients do quite well if they have a peripheral lesion like this lasered. So that's horseshoe tears. Horseshoe tears really are an ocular urgency, and I do think it requires a same-day call to a retinal specialist to discuss when they want to see the patient, potentially treat them. Here's another case, 57-year-old male, just comes in thinking he needs new glasses, has not had an eye exam in over 10 years, and mild hypertension, mild cholesterol, but not on any meds currently. And there's this posterior pole. When we dilate him, and again, these things are hard to take pictures of, but he has a lesion in his eye, and what he has here is a round red hole. I kind of gave it away by saying that, but it's a round red hole, and then just adjacent to it, he has a little schmutza, and that is the technical term, schmutza, floating in the retina, very adjacent to that. So what do you guys think that's supposed to represent? So I'll wait. Well, you got to tell me what it is before you tell me if you can refer or relax, right? So yeah, so people are on the right track. It's an
Hey, Steve, while you're waiting for the answers to roll in there, do you have placeholders for your polling questions?
Oh, was I supposed to do that? I don't.
Okay, that's fine. I have just some polling questions that we want to make sure that we get to at some point. So
If you want to do
That
it,
you sent
why
me.
don't we do it? Why don't we do it after this case? Before I go, after my case 2, I might have a 2C in there before we go to case 3. If you want to do it, then.
okay, that's fine. I just wanted to remind you
Yeah,
that we
sorry
have
about
them.
that.
So,
I
no worries.
probably told me to, and like usual, I probably ignored you. So,
All right, that's fine.
so I agree. So this is an operculated hole. Okay, so that's what people are saying, and I agree. So I have an operculated hole in the left eye. He's asymptomatic. He did not know he had it. So what do you think? An operculated hole, asymptomatic. We asked flashes, floaters. Nope, don't have them. What do you think? Refer or relax? And this one's a little more, a little more challenging. I think the other one, was kind of a little easier. So we got to relax. We have a couple of relaxes there. I agree. These are generally relaxed. And the reason that these are relaxed is I had mentioned earlier that traction is our enemy and lack of traction is good. Well, this particular patient, right? And what we think is when you have an operculated hole, you've had a PVD, it's pulled forward and you get a little hole, but that's why you have the little piece of retina floating, right? So you don't have any traction anymore. When you don't have any traction, you don't really have much risk of things getting worse. If you have traction, like you do in a horseshoe tear, especially a symptomatic tear, those are more worrisome. Now, if you do have a patient with a percolated hole and he says, oh, I do have flashes, maybe you want to get a second opinion on that. It's very rare, though, to have concurrent flashes with a percolated hole, but it can happen. But this is 99 times out of 100, this is relaxed, right? So percolated holes, round red hole, overlying free operculum attached to vitreous. The operculum often appears smaller than the hole, minimal risk as no traction. Because once the traction's gone away, you don't have to worry about it pulling on that hole and making it any bigger. Again, treatments sometimes, right? High myopia, aphakia, history of retinal detachment in the other eye, other factors, like someone said, symptomatic, he's got flashes, floaters, or, maybe he's a monocular patient. This is his only good eye. So there's always mitigating circumstances, but generally speaking, these are very, very safe. And again, I was talking to my retinal specialist one day and I said, hey, Dave, I said, I added a patient on your schedule today. I hope you don't mind, but I really want you to take a peek at him. And he's usually pretty chill. And he's like, oh, that's fine, Steve, no big deal. What is it? And I said, well, it's an operculated hole. And he said, oh, Steve, we've talked about this before. I really don't like to treat, operculated holes. Is the guy symptomatic? I go, no, but the hole's big, right? And he goes, well, how big is it? So I said, well, let me show you the picture. And I showed it to him, and this is a huge operculated hole, right? And I showed it to him, and he said, oh yeah, that one I think I'm gonna treat. And he ended up just doing, some prophylactic laser around it. So again, there's always exceptions to the rule, but 99 times out of 100, these operculated holes are perfectly fine for us to monitor. You can also get atrophic retinal holes. These are small round red holes without an operculum. And they're generally seen in the older folks, about 2 to 3% general population. Again, I feel that's high. Most often in the vitreous base. And they think that what happens in these patients, especially these older patients, they have vascular insufficiency. So the blood supply to the outer retina is not fantastic. And because of that, the retina becomes slightly atrophic, and then they can develop a hole. But it's an atrophic hole. It has no, operculum like an operculated hole, and it doesn't have traction. There's no traction. So because of that, these things are usually found to be very, very safe. So if you see an asymptomatic atrophic retinal hole, you can usually just monitor these things. Sometimes you can get a little cuff of edema around it. Usually you can monitor them, but again, you might want to see that one more frequently, or if you don't like the way it looks, you can get a second opinion. If you see this on routine exam and you ask the patient, hey, are you having flashes, floaters? And they go, oh yeah, I am. Maybe you want to get a second opinion on that, right? Or again, if it's a monocular patient, high myope, or other conditions, maybe you want to get a second opinion to make yourself sleep at night. But these are very, very, very rarely treated because there's no traction. They're very low risk for detachment. And just some other photos here, you know, again, you can see a little one. Wouldn't it be nice if we had arrows in people's eyes to make sure we're not missing any findings, right? Here's another one. You know, here's another one. It's got some pigment around it. Makes you think it's probably been there a while. Probably not a big issue, right? Now, here's one. It's down here in the corner. I'm not sure you can see my pointer or not, but here it is down here in the corner. Yeah, it's kind of a big atrophic hole, and it looks like it looks like it might have a little bit of edema around it too. So maybe I don't like the way that looks. Maybe I want to get a second opinion. Again, here's another relatively large atrophic hole with some edema around it. You know, again, maybe I don't like the way that looks. Maybe I want to get a second opinion. This was from a treatment of asymptomatic lesions. It was from a book that I had years ago that one of my residents borrowed and never gave back, but claims they gave it back. Don't get me started. But anyway, you can see here, this is treatment of asymptomatic lesions. So these are lesions that have no symptoms, you know, and you can see atrophic holes are very rarely treated. Operculated holes, very rarely treated. Lattice with or without holes, very rarely treated. This said flap tears, sometimes treated, you know, faking and high myopia, and usually if they have RD or something else in the other eye. But to be honest with you, most retinal specialists I know will treat even asymptomatic horseshoe tears. This is treatment of symptomatic lesions. Horseshoe tears are almost always treated, to be honest with you. Operculated holes, rarely. Atrophic holes, typically not. Lattice without holes, typically not. Lattice with holes, sometimes treated if there's mitigating circumstances, okay? And this was from the same book. And what it did is just kind of gives you like a flow chart, if you will. But if the patient has lattice or atrophic holes, if they're symptomatic, you know, maybe they get treated. If they're asymptomatic, unless there's, you know, a lot of fluid or something, you leave the patient alone, or if something's wrong with the other eye. If they have a flap tear, if they're asymptomatic, if they're symptomatic, they get treated, period. If they're asymptomatic, they almost always get treated, to be honest with you. So just keep that in mind. Okay, and I saw some questions, attached or non-attached operculum. I mean, you know, the operculum by definition is going to be non-attached. It's not attached anymore. And partial versus full hole. These are generally full holes. It's going to be hard to know that. Greg, I was going to move on to another case here. If you want to throw up the polling question, if you need to do that, this would be a great time to do that.
Perfect. And just to remind everyone, Dr. Saka did around 7:12 put the handout for those who download it from the chat box. So the question is approximately what percentage of lattice results in a retinal detachment? Less than 1%, 10%, 50%, almost 100%. And then, do you want to see Dr. Ferrucci play the piano at the end? Yes, yes, yes.
Or not, it's not happening.
No, or yes. I don't know. It's polling. Polling question out there, Ferrucci.
It doesn't matter. Not happening.
I think the rules are, if it's in favor, I think you're obligated.
Oh, I don't see that. Did you put up the results yet? I didn't see that.
It's not, we're letting it run. We like for it to get to a higher percentage, and it's there. We'll share the results. So the answer to your first polling question, it looks like most of them got it right, less than 1%. And looks like 64% or 53% are saying yes, yes, yes. And another 20%, that's definitely majority of seeing that piano.
That means that 53 and 21% of the people are, in this case, 100% wrong. So, okay. So moving right along, thank you for putting up those polling questions. Oops, let me get rid of that. Just came up. So another case here. So 53-year-old male, left eye blurry and shadow on the left side for 2 days. He had a cataract correction years ago. He thought secondary to an injury, and you can see he's got pretty good vision here. So the patient comes in and his right eye is fine. His left eye, you know, you can kind of down here start to see the retina looks a little bit funny. when you look in the periphery, the retina is really, it's undulated. You know, we're not really seeing the underlying detail. And especially down here, you can see you're not seeing the underlying detail, and that retina is really, you know, flapping around when he's moving his eye. So what do you all think that represents? Anyone? So yeah, so exactly right, a retinal detachment. So this is a retinal detachment. He has good vision, and you know, looking at this top photo, it appears that his retina is, his macula rather, is still intact. So he has a macula on retinal detachment. So is that refer or relax? And some people have already chimed in, but refer or relax. And yeah, so it's refer, right? And again, I mentioned there's not many ocular urgencies or emergencies in eye care. You know, one could argue a corneal ulcer or other things are, but this is a true emergency, especially if it's macula on, because if you have a macula on retinal detachment, the theory is you want to get that repaired before the macula gets off. That gives you the best chance of visual recovery. Once the macula gets off, the chance for visual recovery starts to decrease. So a macula on retinal detachment like this is a true ocular emergency. So this is a call, again, over to your retinal specialist, and they're going to ask you a couple of things, right? They're going to ask you, you know, so you call over to your retinal specialist. Oh, you know, I have a patient with a retinal detachment. They're going to ask you, is it macula on or macula off? Because that helps figure out how fast they need to see the patient, how fast they need to do surgery. So hopefully you can tell if it's macula on or macula off by your clinical exam. And also the acuity isn't the best way to do it, but generally speaking, if they have good acuity, the macula is probably on. If the acuity is lousy, the macula is probably off, right? So they're going to ask that. They're also usually going to ask, you know, can you see the tear or the break that started the detachment? And sometimes you can see them, quite frankly, and sometimes you can't. And, you know, I've had him before. I go, yeah, I can see he has a tear superiorly or inferiorly, whatever. That's probably where the tear started. That's great. If you can't see it, it's not the end of the world, right? So if you can't see it, don't lie and say, yes, I can. Just say, you know, hey, you know, I can't see it, right? So it's as simple as that. The other thing they might ask you is, especially if it's macula on, is when's the last time that the patient ate, right? And why do they want to know that? Well, if they're going to have retinal surgery, if they're going to have retinal detachment surgery, generally speaking, they need anesthesia for this, right? Because it's, you know, they're going to do, usually they do a scleral buckle. They need to put the patient under anesthesia for this. And generally speaking, most anesthesiologists don't want a patient they want the patient to be without food for 6 to 8 hours before they do a surgery in a perfect world. So they want to know when's the last time the patient ate, and it might help them figure out, you know, surgically wise, when they can do surgery on this patient. And that bit me in the butt years and years ago. I was working for Indian Health, and I had a patient with a macula on retinal detachment. I called my retinal specialist, who's in Phoenix, about, you know, half an hour, 45 minutes away. And he said, I'd be happy to see the patient, you know, just send the patient up. And so I told the patient, hey, I'm going to send you over here, and yada, yada, yada. And your patients drive into the retinal specialist's office, and he looks, he goes, ooh, you know, McDonald's, that sounds good. You know, I might be in this doctor's office for a while, makes a pit stop, eats a Big Mac, and then can't have surgery that night, right? So the retinal specialist was a little unhappy with me, you know, and it was my mistake. I just forgot to tell the patient, hey, don't eat anything in case they're going to do surgery tonight. Don't eat anything until you talk to the retinal specialist and they plan surgery. So just something to keep in mind.
So, Steve, one thing that I've noticed that,
yes,
you know, in some of the people, some of the retinal specialists around in our practice and around us,
yes,
you know, not only do you have the issue of eating, but there's the issue of OR time. You know, sometimes they just can't get it, or, you know, sometimes they've got a show to go to that night or a game or something.
yeah.
So what I find is a lot of people will do a pneumatic retinopexy, inject a gas bubble, and, you know, schedule them a couple of days later.
Yeah, yeah, they do. Yeah, we do that. I mean, it's not in a perfect world that wouldn't be done, but yeah, like you say, you know, and one of the problems you have, right, if you're fighting for surgery space, if someone needs a heart surgery that's life-threatening, right, that takes precedence over, an eye surgery, unfortunately. And that's just the way life is. And that's what happens at our hospital, quite frank, a lot, right? Especially cataract surgery, honestly. Cataract surgery will often get bumped. If they're going to do cataract surgery and someone comes in and needs open heart surgery emergently, and there's only one operating room we can use, guess what gets bumped, right? So you bring a good point, but the pneumatic retinopexy can work well on some patients, at least as a stopgap on some patients, but not all patients. But I would still, nonetheless, I make the call to the retinal specialist, send the patient to the retinal specialist. If the retinal specialist looks at patient, says, I'm going to do surgery in 2 days because I'm going out of town for a weekend, sort of that's his issue at that point, not yours. You made the referral, you got them the right person. If they choose to do surgery in a couple of days, that's your case. Now, if you call a retinal specialist, if you have a patient with a retinal detachment, and they say, I can't see him till 2 weeks from Tuesday, call somebody else, because that's not a good idea. But good point, Joe. Most of your points.
Hey, Steve, go back one slide there, and that's, great clinical pearl on the NPO, as they say,
Yeah.
NPO, not to eat after midnight or, in the evening. That's a great clinical pearl. Another pearl, we keep referring to macula on retinal detachment, and you do a macular degeneration talk, and so do I. And one of the things I've identified out there is a lot of our colleagues really not sure how big the macula is to say whether it's, macula on. And one of the things I like to remind the audience is that, remember, the macula in diameter is 5.5 millimeters, wide, or, everyone thinks that when you're looking at this photo here in this upper right hand, that the fovea is actually the macula, right? The fovea is about the size of a disc diameter. It's actually 2 disc diameter. That macula is pretty big, right? It's 2 disc diameters up. It's 2 disc diameters wide. It's 2 disc diameters nasal and temporal, superior, inferior. That macula is big. And if that edge of that macula is on, that's a macula on detachment. It's not fovea on detachment. It's macula. Remember, it's fovea, perifovea, or parafovea, perifovea. That's the whole macula. So you can get pretty far out there and the macula still be on, and you definitely want to get that to a retinologist.
That's a good point. Good point. So this patient ended up having a retinal detachment repair that night, often with a scleral buckle. And often after scleral buckle, these patients will have a big myopic shift because it sort of squeezes the eye a little bit to get the eye in placement with the retina. So it squeezes the eye a little bit, it tends to elongate the eye. So very often after a buccal surgery, you will see some myopia. His vision was 20/50. It ended up getting a little bit better than that. He got back almost the same thing. Now, I talked about macula on, and that's an emergency because you want to get it repaired before the macula gets off. Because once the macula is detached, the vision is going to go south. Even with good surgery, you're not going to get 100% visual improvement. If the macula is off, you still want to make that call. You still want to get it repaired, but you have a little more time on your hands. And there's this old rule of thumb that retinal specialists use. They say for macula off retinal attachment, you want to get it repaired in the same amount of time it's been off. So if a patient comes in and says, hey, 4 days ago, I had a big flash of light and I haven't been able to see in that eye ever since, but I'm finally getting in to see you today, and that happened 4 days ago, you have a couple days window to get it fixed. So it's not quite the emergency because in a way, the damage has been done. So even with surgery, you're going to lose some vision. So the damage has already been done. So it's not as important, but I'm still going to make that call. And I'm going to tell the retinal specialist, hey, I have a macula off retinal attachment. The vision's 2200. He says it's been that way for 7 days. When do you want to see that patient? And hopefully they'll see them that day or the next day, but don't be surprised if they don't schedule them, urgently for surgery, and they schedule them, a couple of days out because it's not as big of an emergency. But macula on RD, that's an emergency, same day NPO. So, these rhegmatogamous RDs, that means you have a tear or a break, right? These occur when liquefied vitreous fluid enters the subretinal space through a full thickness retinal break. They occur in about 1 in 100,000 patients per year. I didn't mention this, but it's funny, these things tend to occur, and they don't know why, on Friday afternoons before a long weekend when all you want to do is go home, right? That's when they tend to happen, when the patient comes in. It's funny, it works that way. Treatment options, there's a lot of different ways to treat these. Sclerobuckles is probably the most common because it's sort of the most permanent, if you will. They can do a pars plana vitrectomy, and like Joe had mentioned earlier, pneumatic retinopexy as well. Now, if I'm going to send the patient over to a retinal specialist, right, I'm not going to tell them, whoops, hey, this is the type of surgery you're going to do. I'm just going to tell them, I'm going to send you over to this retinal specialist. He's going to evaluate you, and more than likely he's going to recommend a surgery to fix this, because these usually require surgery. But they're going to examine the patient, and they look at certain things. So they phakic versus pseudophakic. Where's the tear? How big is the tear? And they'll use that to help determine what's their best course of action. And make sure you have a good retinal specialist ahead of time, not when you need one. I always tell my residents, if you go into private practice, try to get yourself a nice cataract surgeon, a nice retinal specialist, and a nice glaucoma specialist before you actually need them, rather than after you need them, because you don't want to be struggling to find someone on a Friday afternoon when you have an emergency, right? So yeah, and just a couple other pictures here. Here's a nice example, I think, of a patient with a horseshoe tear that's already had a subsequent attachment. And this is sort of the classic, which means it doesn't always happen that way, right? The classic retinal detachment superior, that patient's going to say they see a curtain or something in their vision, right? And this is an example of a patient that, this is kind of what Greg was saying, again, I would probably say, I said macula on RD, but I probably, like he was saying, this is kind of a fovea on RD, right? But the macula is sort of half on and half off, or it's partially off. So this is something that you would want to get over, as soon as possible, because of the proximity to the actual fovea here. So I just thought that was kind of a neat OCT. So again, these are, this is an ocular emergency. You're going to make that call. You're going to get those patients out of your office as quickly as possible. So here's another case. This is a patient 20/20 vision. And when we dilate the patient, he's hyperopic. When we dilate the patient, you can see they have these two funny looking lesions, superior temporal and inferior temporal, in that left eye. So what do you guys think that represents there? And I'll tell you, these things, they're immobile. Unlike a retinal detachment, they don't, move around. They are very taut, and their borders are very succinct. Oh, we got another poll here. I should have per second. So let's look at this poll.
So that's all right. While you're having the people weigh in, Steve,
Yeah.
I was figuring I would just launch this poll.
Sure.
Again, to help and make it live and interactive. You've got the chat question going regarding this picture. This polling question is maybe something from a little bit earlier in the presentation.
Yeah. So which of the following retinal findings warrants urgent referral to a retinal specialist? Perculated holes, horseshoe tears, atrophic hole, or lattice degeneration? Right, so you can go ahead and click on the right one there. But while you guys are doing that, I'll just continue while waiting for the results. But so people have said this is a retinosthesis, right? So this patient has retinosthesis, actually 2 schisis. Very good, very good. Everyone did very good there. So 98% horseshoe tear.
We just discussed retinal schisis as a plural out in Vision Expo West. Did we come up with an answer for that?
Yes. So most people said retinal. Yeah, a couple of people schisis. Yep. So yeah, we did it at Vision Expo West. We had a lovely competition where, was it 8 of us, Greg, that started out? We did head to head, and then we whittled it down to one person that had the best presentation that day. And I forgot who won. Did you find out who won, Greg? Do you remember who won?
Well, I know it wasn't me. And if I think really hard, I think it was you, Dr. Ferrucci.
Oh my gosh, you're right. Yes, I did win. And I'm not one to brag, but I did win.
You did win, but I do recall a time when we had one where you lost to someone that did meibomian gland dysfunction.
You had to bring that up, didn't you? You had to bring that up. That's the day I reconsider my whole life choices and all my choices in life, and have I done everything right? So thank you for that. I appreciate that. So yeah, so that's exactly right. So this is a, hold on here, my things give me trouble. So this is, here it is superiorly, there it is inferior. By the way, this is a camera that I use in my clinic. It's called the Aiden Camera, but it's made by this company Center View, which has now merged with eye care, or eye care bought them out. I don't know the specifics, but I really like this camera. Really nice detailed images. It doesn't quite get out as far as the Optos, but I enjoy the clarity of the images a little bit more. So, you know, there's other wide field images. The Claris is also nice. I think if you're in the market for a camera, it makes sense to consider a wide field camera at this point based on the technology that we have now. So this is a schisis. He has 2 areas in his left eye. And then when I dilated the patient, we dilated the patient, we didn't notice a schisis in the other eye, but when I took a photo, look, he has a schisis in the other eye too. So I thought that was kind of interesting. So is this refer or relax? Anyone to refer or relax? So asymptomatic, they usually are. Schisis, refer or relax. So I just messed up my chat box. Let me get that back here. Oh, son of a biscuit. Hold on. This thing's really giving me a hard time.
So you're having a bunch of people just as you're trying to get the chat box up, relax.
Yep, so that's exactly right.
relax.
So this is relaxed. The only thing I would say that is that, you know, the diagnosis of these can be a little bit tricky. And if you haven't seen a lot of these, you know, maybe you're not sure what it is. If you're not sure it's a schisis, get that second opinion. But if you know it's a schisis, these are relaxed. So this patient has 2 in the left, 1 in the right. I've been following the patient for a couple of years, no change. Here's another one. And I saw this patient, you can see it down here inferiorly. You can see, you know, what I thought was a schisis. But again, this one to me looked a little bit funny. The other one looked very classically like a schisis. This one looked a little bit funny. You know, I thought it was a schisis. You know, you can see the vasculature underneath it. I thought it was a schisis, but to me, it looked a little bit funny. It wasn't as classic as the other one. You can see it here as well. So this one, you know, I wanted a second opinion on just to make myself sleep better at night. I sent them to the retinal specialist, and he agreed it was a schisis. We followed the patient, had the patient come back in 6 months, and you can see that the photo from the first visit to the follow-up visit is almost exactly the same. For all you know, I photocopied it twice, and it's the same picture because you really can't tell. So, so it makes you feel better when you can image these things and look at them sequentially to make sure that there's no change. One of my residents thought it'd be fun to do a visual field on that patient, because if you remember from our days in school, they say with a schisis, you're going to have an absolute visual field defect versus a retinal detachment, you'll have an absolute visual defect. I mean, not absolute, a relative rather, visual field defect. I don't find that horribly helpful, especially since often these things are going to be, you know, pretty far out. You're not even going to be able to catch them on a visual field. But my resident was very excited to do it, and who am I to ruin someone's excitement? So what is a retinosthesis? It's defined as splitting of the neurosensory retinal layers, typically in the outer plexiform layer, and they can look quite different. They can be large, they can be small, they can be bullous, they can be flat, they can be bilateral, unilateral, they can be progressive or non-progressive. So they really have a lot of different clinical appearances. There's 2 major types, acquired and X-linked. The kind I showed you was acquired. And acquired are usually benign and non-progressive. If they are progressive, myopic patients tend to be a little more progressive than hyperopic patients rather. They're typically asymptomatic, found on routine DFE, but they may cause visual field defects. Now, I've seen my fair share of schisises. I don't really know how many. I don't count those sorts of things. I've never had a patient that said, oh yeah, I have a loss in my visual field, right? So can it happen? They claim yes, never happened to me. Incidence, 3.9% in patients 60 to 80. Again, that seems high, or else we're missing a lot of these, right? Most commonly affects infratemporal retina, second most common supratemporal retina, and they're bilateral around 50% of the time. One nice thing is if you see this bilateral, right? If you're not sure, is it a detachment or schisis, and it's bilateral, that really helps you make the diagnosis, because what's the chance that a patient would have bilateral retinal detachments, right? It can happen, but it's not great for sure. So the big thing is you want to make sure that something's a schisis and not a retinal detachment. That's the big deal. And if you're not sure, then you're going to get a second opinion. But schisis, more translucent with visible vasculature. With the RD, you're going to lose the underlying vasculature. Schisises are less flexible. And if you ask the patient to move their eye when you're doing BIO, if they have an RD, the retina will actually undulate. These don't undulate. They're very taut. These have very well demarcated borders, as opposed to retinal detachment that has a more undulated border, overall smoother appearance. And then I mentioned about the visual field defect, which I find relatively unhelpful, but they would have an absolute visual field defect if you were so apt to do that. B-scan and OCT can be helpful. B-scan, B-scan's great. A lot of us don't have B-scans unless we work within ophthalmology. And OCTs are great, but very often these can be in the periphery, and it can be hard to image them. But you can see here, this is a schisis, it's bullous. The vasculature is okay underneath it versus an RD, which is more an undulated border, and you cannot see the vascular underneath there. And if you were to do an OCT, you can see here, this is a schisis because it's splitting within the retina versus an RD, which is coming off the back of the eye. So, they look quite different. But again, this is not an easy thing to do sometimes. B-scan, schisis tends to be more like bubble-like, and then a retinal attachment is going to be more undulated as well. And this one happens to be a bilobal one. So anyway, you can have outer or inner wall breaks. And I remember when I was in school, they told us that one was worse than the other. And I don't even remember which one was apparently worse, but either inner or outer holes can increase the chance for it becoming detached. And if you have inner and outer together, that's a bad situation. So if you see holes either in the inner, which means the kind of the bubble part of it, or the outer layer, which is down the bottom, if you can see a hole, you're going to want to get a second opinion on these, because those are the ones that can be problematic. But if there's no holes, these are generally benign and can be monitored. It's very rare to have detachment into the macula area. They've done studies where they've actually tried prophylactic laser, like around the edge of one of these lesions, to see if that stops it from progressing. And they found that it does not help at all. Not clear why, but it does not help. It's probably because the splitting's within the retina and it's not coming off the back, would be my guess. Cataract surgery and PVD don't seem to have an adverse effect. And again, they generally don't progress at all, and they generally don't progress to detachment. But if they do progress to attachment, which is rare, about 0.05 to a little over 2% of cases, if they do detach, the problem is they respond very poorly to surgery. And I have one patient that years ago I saw, and we followed him for years. He had a schisis that looked good, and eventually it went south. It detached. He had surgery, and unfortunately, he responded very poorly. So a bad situation if that happens. But most are benign, can be monitored yearly unless holes, enlargement, or symptoms.
Steve, just to tie up on retinosthesis, a lot of people have experience with it, and they have their own gestalt. They can easily say, well, I don't see him progress, but nobody really, there's very little that's known about their natural history. But there was a paper out probably a few years ago, and it was a population-based study, not just retinoschisis, but looked at a lot of different things. And what they found in most cases where retinoschisis was present in somebody, on a follow-up, I think 10 years later, they actually had a tendency to regress. They weren't there on follow-up 10 years later.
Interesting.
So not only do they tend not to progress, sometimes they collapse.
Yeah, that's good to know. I haven't seen that paper. It's good to know, because every now and then you see one, and then you look again and you can't find it, and you're like, oh my gosh, I must really be having a bad day. So maybe they've actually flattened out. So it's good to know. I've not seen that. I will look that up. So here's another poll question, and I was just talking about this. So if you don't get this one, I'm going to be really disappointed. in life, right? So which of the following tests can be used to differentiate retinosthesis from retinal detachment? Visual field, OCT, B-scan, or all are helpful in some way, shape, or form.
Oh, yeah, by the way, Steve, we have never gotten 100% on the right answer,
Really?
ever.
Ever?
No. We will during my lecture upcoming, but up till now, never.
Okay, so yeah, so that's good. So, OCT, B-scan, and all are helpful. So I would agree, all are helpful. I would say visual field is probably the least helpful, but all can be helpful. So very good. So, whoops, let me just close that there. Apparently I need to back up my computer. Fantastic. So let's move right along. In the interest of time, because I do tend to talk too much, but this is a patient sent up flashes, floaters, sent up from the urgent care like they always are. And you can see he's on a couple of medications there. We do our due diligence. We dilate this patient. We have a look around, and we've determined that this patient has an acute, not an ugly, but an acute PVD in the right eye. So the question is, an acute PVD with no mitigating circumstances, no holes, no tears, no hemorrhage, no nothing. Would this be a refer or a lax? So I need to send this to my retinal specialist, or can I appropriately see this patient back? And it's actually a two-pronged question because, so most people say relax, and that's exactly right. I do think you want to see the patient back. But
Steve, there was a question in there a little bit about the retinal detachment. It said, always tobacco dust with a retinal detachment. There was a question in their question mark.
I would say usually, I never say always for anything because nothing always happens, but you certainly can get tobacco dusting with a retinal detachment. I wouldn't say you can always appreciate it, or it might not always be there, but in theory, you should have it, but it doesn't always work like it should.
Yeah, and I agree. I do a lot of retina in my area. A lot of people refer in, and you got to be careful always saying always and never in medicine.
Yeah.
Frequently it's there, but a lot of times you see that retinal attachment and you pull that lens, pull that over. I think if they still have some, vitreous intact, you might see it, but if it's very, watery in a sense, I think it just settles to the bottom. So you just got to be careful with that word always.
But in a way, what does it matter? Because you have a retinal attachment. So what do I care for tobacco dust, right?
Right. I guess you're trying to differentiate between that and maybe ascesis. I think that's when that popped in. So
yeah, maybe you're right. Maybe you're right. So anyway, so we want to have the patient back. The question is, when do you want to have the patient back? And when I was a resident, my residency director always told me symptomatic PVDs have the patient back in 6 weeks. So for a long time, I always had the patient back in 6 weeks. Then I had a smart aleck resident ask me why 6 weeks, right? And sometimes I hate residents when they ask you questions because sometimes you have to answer these questions, right? And I said, I have no idea. That's always what I was told. So I actually did a fairly exhaustive literature search trying to find out what is really truly recommended for a symptomatic PVD without a retinal break or other complications. And the AOA says 1 to 2 weeks, which I think is too soon. The American Academy of Optometry says, of ophthalmology rather, says depending on symptoms, risk factors, and clinical findings between 1 and 6 weeks, and then 6 months to a year after that. The Cleveland Clinic, which is a big retina clinic in, where would it be? Oh, Cleveland, that's right. So a big retina clinic in Cleveland, they came out with a white paper a couple of years ago, and they said 4 to 6 weeks. There's other ones that say if there's no risk factors like heme or other issues, you don't even have to have the patient back, because if they haven't had a retinal detachment or break on their first presentation, the chance of having a problem on their second presentation is so low that you don't really need to see the patient back. The problem is a lot of those studies are actually from socialist type medicine where they're looking at the cost to benefit ratio. So I don't think that's the right thing to do for patient care. But I really, through the years, I've really focused on 6 weeks, and I've settled at 6 weeks. And the reason is, if I see a patient back, in 1 to 2 weeks, 99 times out of 100, the patient's still going to have flashes and floaters. And my general opinion is if the patient has flashes, that means they have traction. If they have traction, that means things can go bad. You can still get a detachment at any point. If I have the patient come back in about 6 weeks, probably 99% of the patients, when they come back in 6 weeks, they don't have any more flashes anymore. So I can dilate them again. I look one more time, make sure the retina is intact, and then I'm done with that patient. If I have them come back sooner, I usually have to see the patient back for another visit, which I really don't like to do. So that's why I like 6 weeks. Again, if you like 4 months, 4 weeks, if you like, whatever, or if something makes you concerned, that's fine. But I really like the 6 weeks because by then most patients are asymptomatic and you're good. And keep in mind that the vitreous, what if a patient says the symptoms started 6 weeks ago? I would still see the patient back in 6 weeks. If they still have flashes, I'd see the patient back. So the vitreous attachment was firmly the macula. So what happens in these patients, you have a PVD. The vitreous doesn't want to let go of the macula, right? You can get vitreomacular traction. It doesn't want to let go of the vitreous base because it's firmly attached there. You can get a horseshoe tear. It's firmly attached around the optic nerve head. You get a Weiss's ring. Also, you have some traction on the blood vessels, so you can have a hemorrhagic PVD. You can have vitreous hemorrhage PVD. Studies tell us, though, that patients with hemorrhagic PVDs, about 90% of the time, they actually do have a retinal tear or break. So if you see a patient with a PVD, with a vitreous hemorrhage, you have to be very, very clear and sure that they don't have any retinal attachment, or you get a second opinion if you're not comfortable. As we get older, the chance of getting a PVD increases. And I remember one of my professors back in school threw out this number: 65% above 65 have a PVD. I have no idea where he got that number from, but it's stuck in my head for 30 years now. Incidence may be accelerated by myopia, trauma, vitreoretinal disease, surgery, inflammation. Symmetrical, 90% of the time, happens in the second eye within 1 to 2 years. So if I have a patient, they have a PVD, we do our appropriate follow-up, they come back. I usually tell them, listen, very often this happens within the second eye within a year or two. If it happens with your contralateral eye, please give me a call so we can check it out and make sure it's fine too. The good news is retinal tears or breaks are relatively uncommon with PVDs. One study said 7 to 15% of symptomatic PVDs have a retinal break. The bad news is 7 to 15% have a retinal break. Now, that number to me seems really high, and I actually checked, and this number comes out of a retinal specialist office, right? So he's getting hemorrhagic PVDs. He's getting, weird-looking PVDs. He's not getting the ones that you and I see, have the patient come back in 6 weeks and yup, you're fine. So again, when you're a retinal specialist, you're going to see more complications than an average optometrist or ophthalmologist won't. So I think that 7 to 15% is a little overrated. The point is that you can have a retinal break, and our job is to make sure that they don't have that. Risk factors, right? Inflammatory cells, pigment, Schaefer sign, tobacco dust. If you see these things, it makes you think that they may have a retinal detachment, or a hole or a tear or a break. So you want to really look carefully, or you get a second opinion. And as I mentioned, 90% of hemorrhagic PVDs are found to have a break. So if you're not sure, get a second opinion on those, right? Because 90% do have a break. And a couple months ago, it was right before COVID. So I guess it was like about a year and a half ago. Time flies. We had like 3 hemorrhagic PVDs in a month. And I looked at all of them. I thought they were fine. I had my partner look at them. She thought they looked fine. We said, you know what? I have a retinal specialist handy. Let's have him take a look. He looked. He thought they were all fine as well. But not bad time to get a second opinion. Weiss's ring, Schaefer sign. And then someone asked, do I like to perform an OCT on new PVDs? I do. It's a nice idea because, look, I do an OCT. Here's his vitreous. It's letting go of the macula, no chance for vitreomacular traction. I can clearly see that he's had a PVD. I feel much better about myself by doing the OCT. They're not always as clear cut, keep in mind, but when this happens, it really makes you feel quite happy with your choices in life. I say DFE with scleral depression. And, I'm not the hugest fan, I'm not going to lie to you, of scleral depression, but I think this is a good time to think about doing it. And a couple months ago, there was an article in a retina specialist, retina physician, I believe, magazine. And there were 2 retinal specialists, and they were debating about whether or not you have to do scleral depression in patients with PVDs. And one said yes, and one said no. And they almost agreed on everything because they both said they've never done sclerodepression on a patient with a PVD and learned anything from sclerodepression that they didn't learn without sclerodepression. But one said from a medical legal standpoint, you should do it. And the other one said it's not worth it. So I think from a clinical standpoint, the sclerodepression probably isn't going to help you. But from a medical legal standpoint, it could. And I looked to see what the AOA says about sclerodepression with PVDs. And what it says is you should do it when indicated, but it doesn't tell you these indications, right? And if you ever were to get yourself in trouble, a smart lawyer is going to say, you know, why did you not do DFE? Why did you not do sclerodepression? So that's why I think it's not a bad time to dust off the sclerodepressor and try your sclerodepression and document that you did sclerodepression, right? DFE with sclerodepression. Now, it doesn't ask you, are you good at sclerodepression or how often you do sclerodepression? I did sclerodepression. It's just one more level of protection should things go south. So think about doing sclerodepression in these patients. Counsel patients on signs and symptoms of retinal detachment, increase in flashes, increase in floaters, sudden loss of vision or curtain over the eye. Come back in 6 weeks as long as flashes are present, sooner if heme or high risk. And then once you've gone through this and they're fine, you establish the patient as a routine patient and you have them come back 6 months to a year and document, right? I've done it. I'm sure Joe has done it. I'm not sure Greg has. I don't think we've ever discussed it, but been an expert witness, you know, in a law case, and it's never fun. And I will only represent the optometrist. Recently, someone asked me to look at one, and the optometrist, in my mind, really did not do a good job. And I just said, I'm sorry, I'm too busy. I'm not available to take this case on because I didn't like the way it looked. But you know, if you don't document these things, it's impossible to prove that you educated a patient or that you did something. So make sure you document what you tell the patient, you document what you do. It can really save you someday if things go in a litigious way. So let's, let me see here. We got about 10 more minutes or so, right? Is that right, guys? 10, 15 at most?
Yeah, we started at 7:07, so 47 would be good. If you want to go to 50, that'd be great.
Okay, so here's a patient, 71-year-old male, comes in for a routine eye exam. And when we dilate the patient, we see this lesion here. Now, I couldn't get all the way around it, but trust me when I tell you, it's very circular. It's very flat. We're looking at two-dimensionally, right? Always a disadvantage. But when we looked at him three-dimensionally, we could see that this was flat, had a very demarcated border. And then within the lesion, it had these areas of light areas of choroidal atrophy within the lesion. So people are already chiming in before I even asked, right? But this is a chirpy. This is more than likely a chirpy. A congenital hypertrophy of the RPE. Is this refer or relax? And people are already chiming in. I like it when people actually pay attention. You guys got a good group. I've done this with some groups and you can't get them to answer a blessed thing. So you guys got a good group here tonight. So I like to see that. So this is relax, right? This is relax, congenital hypertrophy, take a photo, patient education, see the patient back in a year. Now, maybe, you know, this is the first time you've ever seen it. You're pretty sure it's a chirpy. You're not sure. Maybe you want to see the patient back sooner than a year. Fantastic. But these things are relatively safe. Unifocal lesion typically appears as flat pigmented round lesions with distinct margins. Color ranges from light brown to jet black. And you have these areas of choroidal atrophy within the lesion. And that's very characteristic for a chirpy. And it's in Latin, there's a word lacunae, which means lake, because these look like lakes. I took 3 years of Latin, and that's all I remember pretty much is lacuna means lake. Typical size 2 to 6 millimeters, but maybe smaller or larger. And there have been ones documented as large as 14 disc diameters or 21 millimeters. Maybe if I saw that, I'd be like, oh my gosh, I want to get a second opinion on that, right? Located anywhere than the fundus, 70% in temporal half, no apparent racial predisposition, although reported more in Caucasians, probably just because lighter fundi, easier to see these things. And they found them in kids that they're screening mainly for retinopathy or prematurity. They found this in kids as young as 3 months old. That's why they think the congenital and not acquired. Just some other photos here. You can see some various, areas there. And this is one that I saw years ago, and it's right near the macula, 20/20 vision, no visual field defect, right? We even ran, I think we did a 10-2. If we didn't, we probably should have. So anyway, a lesion right next to the macula. And I looked at it, I go, boy, that's a weird location, but it sort of looks like a chirpy, right? I sent it to my retinal specialist and he said, boy, that's an odd location, but it sort of looks like a chirpy. He sent it to a friend of his who is an ocular oncologist. He said, boy, that's a weird location, but sort of looks like a chirpy. So we followed the patient and it was super flat. We followed the patient for years and it never changed. So we assume still that it's a chirpy. Right? Could it be a scar from something? Yeah, I suppose, but it's not really going to change my management. The management is to monitor, but just kind of a weird location. Yes, Joe.
Steve, if you're a scar, you'd have some sort of deficit.
You would think, yeah.
The fact you don't have that tells you it's not. Yeah. I saw something even more dramatic, actually going right under the macula.
Oh, really? Yeah.
Yeah.
Yeah. That's weird.
20/20 vision.
Yeah, we think these are in the periphery, but the point is not always. They can be in weird locations. But it makes you pause. It makes you kind of concerned about it. But like you say, asymptomatic, like you say, if it was a scar, he probably would have maybe decreased vision. Looks like maybe it's just missing the macula, but certainly should have a visual field defect. This is another one. It's a bud in the optic nerve head. We thought it was in a melanocytoma or something like that. And again, after years, we just kind of said it's probably a chirpy that's right against the optic nerve. So anyway, lesions are almost stable in size, but color may change. There have been some reported cases in the literature of these getting enlarged with time, but still being chirpies. Personally, if I noticed it getting bigger, on photos, I would get a second opinion on that. Right? Because why wouldn't you? Typically asymptomatic, found in routine exams, large lesions have been shown to have visual field defects. I've had a couple that I thought were within the 24, 30 degrees, tried a visual field, never had a visual field defect, and never had a patient say, hey, I have a visual field defect. So literature says it, I haven't seen it. You can get also multifocal chirpy, right? Often called bear tracks. And this is when you get, rather than one chirpy, you can get multiple in both, or one or both eyes. And I remember, when I was in school, they made a big deal about Gardner syndrome, right? And now they kind of call it familial Adenopus polyposis. And this is a familial condition of colonic polyps that may be a precursor to colon cancer. And in these patients, they find that they have bilateral chirpy in both eyes, but they're usually, in the literature anyway, very multiple. So it's not like you have one or two in each eye, it's like you have multiple. And they also tend to be relatively unusual looking with kind of weird borders and just a lot of them. So, if you see one chirpy or two chirpies, right, you probably don't need to send that patient out for colonoscopy because you'll probably be the least popular optometrist wherever city you practice in, right? I can see that now they're telling their friends, I went in for a new pair of contacts. You'll never guess what I ended up getting, right? But if you see multiple chirpies in both eyes that have a weird appearance to them, always keep that Gardner syndrome in the back of your eye and consider a referral to the appropriate person. So just keep that in the back of your mind. Differential nevi and choroidal melanoma, right? If you call something a nevi that's a chirpy or a chirpy and nevi, no one's going to care because both are benign, right? What you really want to do is rule it out from a choroidal melanoma. That's the big deal. And choroidal melanomas are characteristically have thickness greater than 2 millimeters, whereas a chirpy or a nevus are not going to have that. So with a chirpy, B-scan if you can get it, serial photos, frequent monitoring of assistance, and that sort of thing. Nevi, oops, here you go. One more poll question, then I'll finish up with a couple more slides and then we can get out of here for the night. But which of the following is not a characteristic associated with chirpy, flat, pigmented, indistinct margins, or round?
And Steve, a question rolled in about, can you bill for photos for chirpy diagnosis? And if I can take that or you can take it.
So as I've told you a million times, Greg, I work at a VA. There's no one that knows less about coding and billing than I do. So if you have an answer to that, I'm happy to defer that to you.
Yeah, so the answer would be that, if there's a couple ways I'm going to go with this as the polling question rolls in. A lot of people have, these wellness programs where they're screening for people and they're doing these Optos and, hey, I found something. You don't have to pay for your screening anymore. I'm just going to bill it medical. That's really not the right way to do it. If they're coming in for a screening, you charge them for the screening. And then if you want to bring them back and photo document and bill insurance, then do it that way. So for a chirpy, you're doing an exam, you find this black spot in the back of the eye and you say, hey, you got a chirpy back here. In this case, what you have up on the screen, a nevus. Sure, you can bill for it. But the key is you just can't keep billing for it and billing for it and billing for it. You have to have some type of change. And that's why you take the photo. Supposedly you take the photo, you put it up there because next time you see them, then you're referencing it as you're doing your exam. And if you see a change, then you can again bill for another photo if you want. So the answer is long drawn out way. Yes, you can bill for a chirpy. It's just not time and time and time again that you keep pounding them for it. It's so that you have it to reference it to see if there's any change.
Fantastic. Great answer. I would have just said no. I'm just kidding.
So let me end the poll here. It looks like it went very well. I'll share the results for you.
Yeah. And, so fantastic. Fantastic. I just wanted to get 100%, Joe, but I guess not. 99 times out of 100, these nevi are fine. Every now and then you see a funny looking one. This is one I saw. I thought it was funny looking. We followed this patient for years. They determined it's an amelanotic nevus, a nevus without melanin. So there are some characteristics that every now and then you want to get a second opinion. Let me just close with one thing about nevi. So there was this old study done by Shields and Shields, who are two ophthalmologists out of the East Coast. And they looked at characteristics of lesions and what made these lesions more likely to not be, a nevi or a chirpy, but in fact, an ocular melanoma. There's this old mnemonic, to find small ocular melanomas. So T is for thickness. Any lesion greater than 2 millimeters is very suspicious for being a melanoma. F, fluid, any subretinal fluid suggestions of retinal detachment. S, symptoms of photopsia or vision loss. O, orange pigment overlying the lesion. That orange pigment is lipofuscin. Lipofuscin is released when the retina is dying. And then M, margin touching the optic nerve head. So what they found was if they had none of these factors, they had about a 3% risk of converting melanoma, one factor about 8%, two or more factors 50%. And of these factors, they found that thickness was probably the number one important factor, right? So if you have any of these factors, whenever you see a lesion, think about these things. If they have any of these things, you might want to think about getting a referral. If they have two of these things, you definitely want to get a second opinion. And if they have thickness, that can be bad. A couple of years ago, the same doctors, Shields and Shields, looked at this again, and they changed it a little bit. Now they have it to find small ocular melanomas doing imaging. So T still stands for thickness, F, fluid, S, symptoms of vision loss, O, orange pigment, M, melanoma hollowness. What they found was the margin touching the optic nerve head wasn't that important. They replaced it with melanoma hollowness. So if you do an ultrasound and it's hollow, that's a bad thing. Most of us don't have an ultrasound, so that's not hardly helpful. And then diameter, they found that things over a 5 millimeter diameter are a little more likely to be possibly melanomas, but that was a very weak association. So what they found again in this newer study, if they had none of those factors, a 1% risk, one factor, 11%, 2, 22, 3, 4, 5, and so on. So as you get more risk factors, that imparts a greater risk of transformation to a melanoma, and then you would want to go ahead and get a second opinion certainly on those. So tumor margin, now ultrasound, vision loss rather than flashes, floaters, most important thickness, fluid, orange pigment hollowness, least important symptoms, and the diameter. So, that's pretty much, and this is just an example of a patient I saw years ago, and you can see that this is, you look at this, it's elevated, this is, you're obviously going to refer, and you can see on the OCT. It's got fluid, it's thick, not a good situation. So you're going to get a second opinion on that. So with that, I'd like to conclude and say thank you guys for putting up with me tonight. And, there's just one other question. Would you refer melanoma as none of these factors which shows minimal growth over 7 years? Yeah, if I can document growth, I'm going to say, I'm going to get a second opinion on those, right? Any growth to me is bad. So if I have any growth of it, I am going to get a second opinion on that melanoma. So, so with that, I think I'll conclude unless there's any further questions from the people. No, there will be no piano tonight. I hate to break it to you, but there'll be no piano. So any questions, Joe or Greg, anything we didn't address that you feel needs addressing?
I thought you were very comprehensive. You have a great experience and command of this information, and a lot of the details that you went into are things that people take for granted, but maybe just don't really know in terms of the pathophysiology of all this. So it really was a great learning experience, I think, for everybody, Steve.
Well, thank you, Joe. Coming from you, that means a lot.
And Steve, if you look into the chat box there, you're getting your virtual round of applause of thank yous and top 3 lectures, and very useful every day and practical. So you're getting your virtual round of applause there.
Someone said top 3. I want to know what the other 2 were.
Yeah, it was Joe, me, and then you. Sorry.
Yeah. All right, I can live with that. But thanks, guys. I really appreciate you having me to be a part of this, and I really appreciate it.
Yep. Thanks, Steve. And that will conclude the CE part. Thank you, Dr. Ferrucci, for doing Retina, refer or relax. Again, as Dr. Saka mentioned, very comprehensive, very practical.